Welcome to everybody. Um, I am going to spend an hour and a half of your time trying to share some few quick things with you. And I know some of you may have some experience in ortho. Some of you may not. Some of you may be thinking of taking the series. Some of you may have already taken it. I don't know. So for those of you that have taken the series, some of the things that I'm going to discuss, you may already know, but at the same time, I'm going to try to sprinkle in a few extra things here and there for those of you with a little bit of knowledge, just so it's worth your time as well. So a little bit about me. I am from the state of Ohio, the Ohio State University, OH. None of you know what that means, but that's okay. I have been an instructor for Progressive for 17 years. So I've been doing this for quite a while. My colleague, Dr. Taylor, who is on here, I think he has been doing it for how long, Dr. Taylor?
39 years.
39 years. Dr. Taylor was one of my mentors when I learned how to do this. So it's nice to make friends and also get a good education. Okay. So I and as well as Dr. Taylor, we're both senior instructors for Progressive Orthodontics. I am a general dentist. I do not practice dentistry. I gave that up 3 or 4 years ago, and that's one of the greatest, most relieving things I've ever done in my entire life. So I practice only orthodontics, and I've also run a specialty practice. So I know what it's like on that end of the spectrum. I know what it's like from ortho as a general practitioner side of the coin, and I know what it's like from the specialty side of the coin. So I feel a little blessed that I've been able to do both of those. Right now, I work in a practice where the owner of the practice has 7 offices, and basically what he does is he feeds me all the ortho from his 7 offices. So that's what I do now. Okay. For those of you that are considering taking the program that aren't really knowing a whole lot about it, I am going to show you a little PowerPoint to start with and kind of give you a little introduction to who we are. Okay. So let me share my screen and okay, and this PowerPoint is courtesy of a couple other senior POS instructors, Dr. Michael Krenrick, who is in Germany, and Dr. Hans de Bruin, who is in Belgium. Okay, POS is not a national company, not just a US company. POS is a global company, and this seminar series has been taught all over the world for many years. Okay, so is it the missing link in general practice? I would say so. You know, I tell people a lot this saying, and it's really hard to appreciate until you've actually lived it, but you really can't be a good dentist, in my opinion, without knowing how to do orthodontics. Okay, you have to at times be able to get the teeth to move into the proper position to do the proper restorative that you want to do. Okay, this company was founded by Dr. Don McGann. We have been teaching ortho seminars for over 30 years, Europe, Africa, Australia, Asia, and the United States. I've been fortunate enough to teach in all these places with the exception of Africa. So it's been a wild ride for me. But you know, the other benefit of that is seeing cases from all over the world gives us a lot different perspective than a lot of companies where you're just seeing one type of patient. So we try to give you a diverse quality of patients. Okay. The instructors, we have teachers from 4 continents, all are general dentists, all took POS training and all work with the system. Okay. I guess I'm a poster child for that, if I want to say that. I learned orthodontics from Progressive in 2005. And that was what I always wanted to do. You know, a little background on me. I had the grades to go to ortho school. I just wanted to get out of dental school and I wanted to get a job and get married and all this other. And I didn't go into ortho. I considered going back to ortho school. Instead, I took progressive, and that is where I've gotten all of my training. And it trained me well enough that I can run a specialty practice. Okay. Specialty practice is a whole different can of worms. In a specialty practice, I was seeing between 80 and 100 patients per day. Okay. Because an ortho practice is totally different. In an ortho practice, I'll have 6 chairs with a staff member at each chair, and I'll have another staff member floating that's sterilizing instruments. And we have one assistant that's dedicated to records as well. Okay. So for me to be able to do that with only the training that's come from progressive orthodontics, I think that speaks volume for the quality of the education. Okay. I will also say that in Indonesia, I don't know if it's still the case or not, but for a while we were the university orthodontic training. So it is a program that's designed to be of that caliber. Okay. Of that caliber, excuse me. Okay. We do use our own diagnostic system. We do use our own software. In a couple of minutes, I'm going to show you the software. We have a software called SmileStream. Okay. SmileStream, one of the beautiful things about it, couple really nice things about it. One, it gives you a place to put all your data. Okay, it gives you a streamlined place to collaborate your data so that you can go and find it easily. Okay. Another feature of SmileStream is it has something in it called DentalCAD, which gives you the ability to trace a Ceph and the ability to trace models on the computer. And then just with the click of a button, instead of having to measure all these angles and all this other busy work is what I would call it, the computer does it all for you. Okay. And then you have the ability to combine the Ceph and the models to create something called a VTO. Okay. A VTO is a visual treatment objective. It gives you an idea of what your case is going to look like by doing various treatments. Okay. So you have an idea of where you're going before you go there. And that sounds like, oh, well, that's great, but is it really going to happen? Well, the beauty of it is the way we evaluate an orthodontic case, the way we evaluate what happened is we do an overlay, which is something where we take a beginning Ceph and we take a final Ceph when we lay the two on top of each other and see what actually happened. The VTOs and the overlays, when the orthodontics are done as we suggest, are very, very accurate. Okay. We do also have a complete set of treatment plans for every ortho case in your practice. Okay. I don't like to call it a cookbook. Some people like to call it a cookbook. It's not really flattering, but you get detailed instructions on how to treat every case in your practice. You also get support as much or as little as you want. Okay. If you want no help, you have the option of having no help. If you want an instructor to help you diagnose a case, you have that ability. If you want an instructor to mentor your case with you, where they'll hold your hand from the beginning of the case to the end of the case to ensure that you have beautiful results, you have that option as well. Okay. In addition, you have free lifetime retakes. All right. So once you've taken the program, we feel that you've paid for your education. So as much as you need to come to feel comfortable, you're welcome to. And we have different options. We have computer options, we have live options, and some of the POS people can discuss those options with you. Okay. Differences with other programs. I'm going to tell you one of the biggest things that I find from other programs is our seminars have structure. Okay. And our seminars are developed to build upon one another. So you have structure. I know that there's other seminars out there where they bounce around all over the place and it gets confusing. It's sad to say, but a lot of students that take other programs, I'm not going to name other programs, but it seems that most of those students that really want to learn how to do ortho end up at POS. Okay, they feel that they have deficiencies in the existing system that they learned, and they end up with us. So it's pretty rare that you're going to find somebody in another class, another system that was trained by us, and they feel that they don't understand it and have to go elsewhere. Okay. Another beauty, it's not talent dependent. Okay. We suggest, now you can do whatever you like. We suggest that you use something called an IP appliance. Okay. It is an individual patient appliance, and honestly, it gives you beautiful results, and it is very competitive in price. Okay. You know, if you want to talk about price, $200. Okay. You can get your bands, your brackets, your arch wires, everything for the case for in materials for less than $200. And I don't know what it's like where you practice. Where I practice, the going rate 6,000, and we're low. Okay, so I'm hearing 7,000 to 8,000, and I've got $200 in it. Okay, so if you want to use another system, you're not learning a system. You're learning orthodontics. Okay, but IP is designed to minimize wire bending. Okay, that's something that's talent dependent. Okay. Some people are better at wire bending than others. The only way that we can guarantee all of you excellent results on your first cases is to suggest you use a bracket that's going to make your life easy. Okay. I will tell you this, most of you won't believe me, and that's okay. I hope you do take the class, but the first cases you do, honestly, will be, I guarantee you, some of the most beautiful cases you ever do in your entire life. Most of you think, oh, my first case, I'm going to slop it around and I'm not going to do a very good job, and so I'm not going to charge them very much money. Honestly, your first case is, you're going to be so meticulous about every little thing that you do, your case will turn out beautiful. Okay. It's later on, whenever you start getting sloppy, you know, you get experienced, and then you're just throwing brackets on real quick, that your cases don't turn out as beautiful. So, and there is a fine line between being meticulous and being efficient. Okay. But we do want you to be successful. Okay. Why do you want to offer this in your practice? I'll tell you what, because it's going to be one of the most profitable things you do in your office by far. I mean, if I can charge $6,000 for a case and I have $200 in it, that is quite a profit margin. Okay. You're going to get more services from your existing patients. And then as you do ortho, you're going to get more new patients. And what will happen is, with the ortho patients, a lot of them will want to become your dentistry patients as well, because they're at your office. Okay. Some people think, oh, you know what? I'm a general dentist. They're not going to want me to do ortho because they're going to want a specialist to do it. Really? You're the one they trust. They trust you to treat their family. And I certainly think if they trust you to treat their family by giving them injections and things like that, they're going to trust you to straighten their teeth. And I'm sure they'd rather give $6,000 to somebody they know and trust rather than just some stranger, you know? So I'll tell you the other beautiful thing, and this is going to have a little bit to do with the case that I'm going to show you in SmileStream in a minute. What happens is, a lot of these families that I see have multiple children. So it's like, as soon as one of them comes out of braces, the next one goes in braces, and then the next one goes in braces, and the next one, you know, and so on and so forth. You know, it's a beautiful thing. So, all right. So we focus on fixed buckle appliances in the fixed seminar series. Now, if you want to learn aligners, we also have an aligner series where we can show you those kind of things. Okay. And you're welcome to get that kind of education as well. But aligners are not covered in the basic fixed series. Okay. And these are linguals, and we also don't teach linguals. Okay. All right. So different cases have different levels of difficulty. Okay. You don't have to treat every case. That's another beautiful thing about being a general dentist. You can treat the ones you want to treat and refer out the ones you don't. Okay. Now, let me ask you a question. What's a better case for you to start with? The one where their teeth look like this, or one where the teeth look like this and one of the teeth is out of line. Okay, a lot of people think, oh, I want to start on that case where there's only one crooked tooth, and then that way I can make sure that I can straighten that one crooked tooth. When a person only has one crooked tooth, that's a lot harder to make look good than when they have every single tooth in their mouth is crooked, right? So the person that has very crooked teeth, a lot of crowding, that is a great case for you, okay? So that's what we're talking about. Low cost, no special talents. There's really not, there's some lab fees for some appliances, but not very many. And we are here to back you up every step of the way. So hopefully that gives you some confidence. Okay. So we have section training where we train you in the different levels. Okay. Maybe. Okay. So these are how we define early cases. Okay. Again, would this be a good early case? This is a great early case because it's almost class 1. It has anterior crossbite, which is right there in the front. So the patient's going to see the results quite quickly. Okay. That is a beautiful case for you to start. What we're going to want you to do in the beginning is try to start with 4 millimeters of class 2 or 4 millimeters of class 3 or less. Now, our seminar series doesn't just teach permanent dentition. We also teach mixed dentition. Okay, so there's a whole section on how to treat children. Okay, and I know some orthodontists treat, well, I'm going to rephrase that. I know that most orthodontists do not treat children. Okay, and you know why most orthodontists do not treat children? It's not for the benefit of the child, it's profit. Okay, if I can have 6 chairs with $6,000 in each chair, why am I going to put a mixed dentition in one of the chairs that's I'm only getting $3,000? It's not profitable, so they wait. Now, my question to you is that in the best interest of your child to wait? Now, you're not the doctor anymore. Now you're the parent. Okay, so is it in the best interest of the child to wait? Sometimes it is. There are some cases where there's no sense of putting anything on there until you're at full eruption. Okay, but there are some cases, especially where there are skeletal issues. Okay, a skeletal class 2 or a skeletal class 3. Okay, or especially a transverse problem. There are a lot of children with transverse problems. You need to get that corrected as early as possible so the child has the ability to develop correctly, okay, to create an environment for proper development. So I would encourage you to take mixed dentition cases, okay? You can take orthodontic surgery cases if you want, okay? We're going to give you that kind of training. Whether you do it or not, that is up to you. Again, you're only limited by your comfort level, okay? So we also do teach skeletal anchorage as part of the series, okay? I don't know anybody else that teaches that kind of stuff, okay? I can show you some things with skeletal anchorage that I will show you a couple things with skeletal anchorage that'll blow your mind, okay? And if they don't, you're asleep because I think they're pretty impressive, okay? So here's a little class 2 div 2 case, probably, maybe some spacing, something like that. Okay, that's a good one. Okay, a beautiful result. And this is the kind of results I expect you to get, okay? I expect your patient, if someone looked at them, well, let me put it this way. This is my standard criteria for you treating your patients. Your level of care has to be equal to or better than the specialty. Okay, that's what I expect from all the students. I want the care to be equal to or better than the specialty, okay? Anything else, I don't know why you would want to learn anything else because that's your market, okay? And you've got to give these kids good looking teeth, okay? Section 2 cases, these are maybe extraction cases, all right? We're not just a non-extraction company, okay? Some cases you have to extract. Of course, we try to avoid extraction, but sometimes that's not feasible. So, you know, if somebody has a mile, I know I'm being facetious, but if somebody has a mile of lower crowding and a mile of upper crowding and you straighten their teeth are just going to fly forward. Their bite's going to fly open. They could be protrusive. It's going to be a mess. So sometimes you do have to extract teeth. Now, a common misconception is that extraction equals retraction. That is not true, okay? Because we have something called anchorage, okay? And anchorage is how we control the movement of teeth. We control the movement of the front teeth. We control the movement of the back teeth, okay? So if somebody had 16 millimeters of lower crowding and you took out 2 bicuspids, now 2 bicuspids are 8 millimeters each, the crowding would consume all of the extraction space and the incisors would not retract at all. So extraction does not equal retraction. You can control the tooth movements. Now, the primary methods of tooth movements that we use at POS, in extraction cases, we like to use something called a closing coil. It's a spring that you can stretch out, okay? It starts out like this, you stretch it out like this, and then when it sits there, it wants to go back to closed again, okay? And as it goes from open to closed, it closes the extraction spaces. And by varying the amount of stretch of the coil, you can control whether the front teeth go back or whether the back teeth go forward, okay? In non-extraction cases, we're primarily using elastics, okay? You're using rubber bands to correct the bite, okay? In many extraction cases, you're going to use coils to close the spaces, but if you don't get the bite exactly class 1, you're going to end up having to use some elastics at the end of the case to get the ideal overjet, okay? So this is a little bit more complicated of a case than the first one. There's a lot of crowding. If you look at the lower, a lot of crowding in that arch, okay? I think it turns out beautifully. And if you look, they took out upper and lower first bicuspids and you get a beautiful result, okay? Okay, section 3 cases, these are the ones with a lot of overjet or a lot of deep bite or something like that, okay? These are the cases that are going to make you work. Now, I'm going to show you here in a little bit, I'm going to show you an extraction case that started with deep bite. Now, you're going to learn that when you extract on a case, the bite gets deeper, okay? So, it's a complicated case, so that's why I want to show it to you, okay? But again, a beautiful result, okay? This is the result I expect on every single one of your cases. This is going to require a little more work. Now, the beauty of this case is, well, let's see, it went non-extraction because it was spacing, but look how much they opened up the bite. Okay, that's impressive. Section 4, that is beyond the first 12 seminars, okay? So that's some additional training if you want to learn things above and beyond what you learn in the basic series, okay? In the basic series, in the first 12 seminars, you are going to learn enough to treat, I'm going to say 95% of the cases that walk through your door, okay? There's going to be a 5% of the cases that that you're going to need some additional training, but it's a lot of multiple coil, skeletal anchorage, and things of that deal. It's really trying to change people's faces without orthodontic surgery. That's what it really boils down to, okay? Okay, this is a harder case. Okay, it's a lot of crowding, deep bite, a ton of overjet, a bunch of class 2, it's a mess. Okay, you can make it turn out beautiful, but again, you need more training, okay? This is another example of a section 4 case. This is orthodontic surgery with extractions, okay? And yes, you're going to learn orthodontic surgery. But Dr. Weir, or everybody calls me Shock, okay? My first name's Shockley, everybody calls me Shock. Shock, I don't want to do surgery cases. Then don't. It's fine. But if you want to do them, we will train you how to do them. And we will help you along the way if you so desire, okay? One of the most important things on surgery cases is you just have to make sure, you have to be able to identify what is a surgery case, because I don't want you to go into a case thinking it's just braces and it's actually surgery and then you get in trouble. Okay, here's mixed dentition. We talked about that. Okay, we're looking for a lot of different things that we are looking for in children. My opinion is every 8-year-old should have an ortho screening, okay? And if you see any of these issues, then you need to deal with them in phase 1, okay? Okay, so these are just some examples of some different ones. You know, here's a phase 1 that needs to be treated. This is probably a thumbsucker or a pacifier habit or something. Once you get past 6 years old, you have to address these things, okay? So this is just some other examples of things that you can see in phase 1, okay? Adult patients, that's another whole different can of worms, okay? I'm going to tell you the majority of ortho practices and the majority of areas where they do ortho in the practice, the majority of the patients are going to be teenage kids. That's your bread and butter, okay? The high school kids, that 7th, 8th grade through high school, that's your moneymaker, okay? But ortho adult patients, there's going to be adult patients too, patients that didn't have the money when they were a child, or their parents didn't have the money for them to do ortho, and they've always wanted their teeth straight. That's a whole different can of worms, okay? It's not that moving teeth is any different, but it's a different kind of patient to manage, okay? But you can get beautiful results, okay? TMJ problems, you need to consider ortho. It could be the bite contributing it to it. Perio problems, you need to consider ortho. It gives you a better environment to keep your teeth clean. Pre-restorative, big time, okay? I mean, sometimes you cannot do good restorative without knowing how to do ortho, okay? People that have mutilated their teeth, okay? So there's a ton of different patients that you can treat, okay? So we suggest you start looking for average and avoid the extreme patients, okay? We are going to teach you a straight wire system, okay? It's based on a Roth appliance, okay? Generally speaking, we use a 22 slot, okay? There's 2 general orthodontic systems. There's systems that use 18 slots, and there's systems that use 22 slots. We like to use a 19 by 25 stainless steel wire in a 22 slot. It gives you a very rigid arch wire on which to do your mechanics. And that also decreases some of the unwanted tooth movements because of the rigidity of the arch wire. Some people use 18 slots, but and when I worked in the ortho practice, that's what I used, 18 slots. And I have to tell you, generally speaking, I prefer a 22 slot better. It's a heck of a lot easier to put the legs on the lower incisors too, because those 18 slot brackets, those things on the lower incisors seem tiny, and it's hard to get the wire into the hard to tie in the arch wire. Okay. Another beautiful thing is I think we have 18 different shapes of arch wires. Okay, which is something that no other company has. Okay. We offer different brackets with different amount of torque. Okay. It's not good enough to just make straight teeth. You have to make the straight teeth have a nice inclination, okay? If the incisors don't have a nice inclination, then in my opinion, the case looks terrible, okay? And I've seen a lot of specialists spend up very profound, a lot of specialists like this. And I've seen a lot of specialists finish like that. They're very profound and very retroclined, okay? And by using IP, you can avoid that problem. You know, the practice I work in now, I can use any system I want. Okay, I can pick whatever I want. Okay, I use IP, all right, because it gives me beautiful results with a minimal amount of work. Okay, so this just shows you one of the brackets. the torque and angulation are pre-programmed into the brackets. Okay, so let's look at SmileStream. Okay, so SmileStream is our software that we use for patient evaluation. Okay, so let me share my screen with you. Maybe, hold on just a second. The reason I decided to show you this patient is the following. All right, so this is the patient. This is
there you go.
This is Dominic, okay? So, all right, this is Dominic. Now, if we look in this software, this is called the picture tab. Okay, and this is where you create something called an orthodontic collage, okay? To do ortho, every orthodontist that you have ever sent a case to, they probably sent you back a piece of paper that had some photographs on it, okay? And it's called an orthodontic collage, okay? This is where you put those photos, okay? This is Dominic. Obviously, my assistant didn't focus that one, right? But here he is smiling. Okay, here he is with his lips at rest. A little bit crooked. Kind of crooked. Now, you probably don't, here's some crossbite right here. And he's got a bunch of class 2. Okay, a lot of class 2. Okay, he's 8 millimeters of class 2 right there. You guys don't understand that, but you'll learn how to see that, okay? So he's 8 millimeters of class 2. He has, I don't know, 3 or 4 lower crowding, one of which is in crossbite, right? Some upper crowding and the crossbite also, okay? You also have a panoramic x-ray, okay, looking for missing teeth, looking for impactions and things like that. Yes, you're going to retrieve impacted teeth, okay? And here's his lateral set, okay? So what we do is we go through the tabs and we enter data on the patient. So this guy is class 2. I think he's a little more class 2 than what we have noted, so we're going to change that. Here you can evaluate a functional shift is whether it's like a hit and slide whenever you have dentures. Have you ever heard of somebody, they say, I hit and slide? That's a functional shift, okay? They bite one place, it's just their natural bite, but they get a premature contact and slide somewhere, okay? You can evaluate the vertical dimension, whether it's permanent dentition, evaluate the tissue thickness, okay? Now, there's 4 reasons you're going to have to extract teeth, okay? One of the reasons you're going to have to extract teeth is protrusion. Your teeth stick way out of your head. How am I going to get space into which to retract your teeth? Okay, I'm going to have to pull some teeth to get some space to be able to retract your teeth enough to give you a significant decrease in your perception of protrusion. Okay. A massive amount of crowding where sufficient crowding that the patient's profile or lower anterior tissue cannot tolerate the advancement. Okay, that's a reason to extract. A big class 2 or a big class 3, like more than 4 millimeters. 4 millimeters of class 2 or class 3 is the most you're fixing. non-extraction with a rubber band, predictably. Okay. More than that, you may need to extract. Okay. And open bite, you would consider extraction because as you extract and retract, the bite closes. If you go non-extraction and the teeth advance, the bite opens. Okay. So he's got some crowding. He has a posterior unilateral crossbite. So that is a dental evaluation. Okay. Here's a facial evaluation. What does the patient's face look like? Okay. Where's his upper midline? What do his lips look like? Does he show gum? Okay. What's his sublabial fold look like? His nasolabial angle? What are his lips like? What's the overjet? Does he breathe through his mouth or nose? Does he have habits? Does he have TMJ issues? Okay, this is something I want to show you though, because gingival display, some of you are saying, well, gingival display, well, you can't really do anything about that anyway. I will tell you this, an orthodontist, if you have a patient go to an orthodontist with gingival display, they are going to have one treatment, and that treatment is going to be orthodontic surgery, maxillary impaction. Okay, now I'm not saying you have to do this, but we will teach you to do this in seminar number 9. So if you look at this young lady, sorry, I'm trying to move this. She has straight teeth, but she shows gum, right? Can't make her teeth any straighter than that. They're straight. Okay. How about you put 2 little screws in there? How about you put a little bone plate right here in the vestibule? And how about you run a spring from that bone plate to the arch wire? Okay. Now the spring, the windings are together when you start, and then you stretch them out. And then when you go again, as time goes by, the windings come back together. Okay. The spring can't pull the bone plate down, so the only thing it can do is pull the arch wire up. Okay, so my question to you is, do you see any difference? Okay, if that doesn't impress you, you're dead. Okay, because that is beautiful. And the thing about that is, an orthodontist is going to say orthodontic surgery. Okay, you can do this with 2 tiny little pins, one right here and one right here. It's simple. And you know what? If you're not a surgical person and you don't want to do the surgery, that's fine. We have a surgeon's referral manual that's written by an oral surgeon to explain to an oral surgeon where to put the screws. And the surgeon will love you because it's so easy to get in, and they're going to get $1,000 a screw. So $2,000, it's going to be super easy. And you can get results like that. Nobody else in your block can get that. That's going to make you better than. Okay, remember I said equal to or better than. Let me show you another one. Because that's skeletal anchorage, okay? That's the power of skeletal anchorage. Let me show you another one. Sorry, it's taking a second for it to open up. Okay, my question to you, doctor, is how are you going to restore the lower right quadrant? Put an implant in there and have them occlude on the healing cap?
Shock, I can't see the PowerPoint.
Oh, I'm sorry. Thank you for telling me.
Hmm?
Okay, so there we go. Is that better?
Yes.
Thank you. Okay, so again, doctors, how are you going to restore the lower right quadrant? My suggestion was an implant and have them occlude on the healing cap, and the healing cap's your final restoration. That's sarcasm. Okay. What are you gonna do? Grind this tooth down and hit the pulp? Do a root canal on it? Put a stub crown on it that falls off all the time? how about you intrude the molars? Okay, so that you can do a proper restorative. And I want you to call the orthodontist. When you call the orthodontist, say, hey, can you intrude molars in your practice? And he'll say no. And you'll say, well, good, I can in mine. And then you hang up. Right? Does that look better? Can you restore the lower right quadrant properly now? And on the left, I mean, look, what are you going to do? A stair step thing on the bottom? That's going to be a joke for the restorative. Why don't you get things aligned properly so you can do your restorative properly? That's what I would suggest. Okay. So anyway, let's go back to Smile Stream. Hang on just a minute. Okay, so you can go through and you can add the patient expectations. You know, what is the patient expecting? Patient wants non-extraction. Well, of course, everybody wants non-extraction. What's their chief complaint? Crooked teeth. Okay, you got to make sure you can solve the chief complaint. If you can't solve the chief complaint, don't take the case, right? What are your goals and what may prevent you from getting there? Okay, I want to straighten the teeth. I want to fix the class 2. What might I not be able to correct? I might not be able to correct the class 2 unless he cooperates, right? So if he doesn't wear his rubber bands, I might not get the class 2 corrected, right? I might not get the midlines. All right, now I want to show you dental CAD. Dental CAD is where we do ceph tracing. So I'm going to make a copy of this. I'll do that in a second, guys. Just give me just a second. I just want to show you how the ceph tracing works. So I just need to get a clean ceph here. So you import the ceph into your software and find it here somewhere. There it is. And it has to think for a second. For a long second. Okay. So what I'm going to do is create a new lateral ceph. So March progress. Okay. Perfect. All right. So I'll trace this one for you real quick and just show you how easy it is. Okay. Now you're not going to know the points, but every time you click a point, the computer goes to the next point for you. So there's Nasion, there's Sella, there's Porion, there's Orbitali, there's center of cranium, There's posterior nasal spine, anterior nasal spine, A point, B point, gonion, gnathion, menton, gonion, condylion, tip of nose, subnasale, stomion, soft tissue begonion, tip of lower lip, tip of upper lip. Okay, now you put the teeth in there. Okay, and put the teeth in there. And you're going to learn to do this in seminar number 1. So you'll have exercises where you practice this and so on and so forth. Upper molar, lower molar, symphysis. I'll zoom in a little bit, I can't see. The mandible. Okay, the lower profile. And the upper profile. You can see it really doesn't take a whole lot of time. Now, granted, I've done it once or twice, but it really doesn't take that much time. And the maxilla. Okay, and then when you've done that, it gives you all of these cephalometric numbers, and these are going to mean something to you at some point in time, okay? If you decide to learn this, there's a cephalometric tab that brings in all the cephalometric numbers, and this gives you a lot of data, and there's certain data that's extremely relevant, and there's some that's not as relevant, but that will all be part of your education, is learning to interpret ceph data. Now, the beautiful thing is, in dental CAD, now I'm not going to do this for you because it takes a minute, okay? But I mean, it doesn't take that long, but I don't really want you to sit and watch me do it, okay? This is called model measuring. Maybe. Okay, now these are digital models, okay, which you get from a place called OrthoSelect, or if you have iTero or something, or you have a scanner, you can just use the scans, whatever. Okay, but this is something where you trace the models. Okay, and the name of the game is you have to have the same amount of crowding that you see visually has to match the computer's estimation of crowding. Okay, and then what you can do is you can hit a button and combine the ceph and the models to give you various treatment outcomes, give you an idea of what things will look like if you go non-extraction, if you take out upper fours, I'm sorry, you don't know what that, take out upper first bicuspid. That's one thing about ortho. Ortho is a different tooth numbering nomenclature. The only place that uses 1 through 32 is United States dentists, okay? So we number teeth differently, so you'll learn about tooth numbering system because we number them the way the orthodontist and people throughout the world number them, because again, this is a global company. Okay, so you could take out upper first bicuspids only. You could take out upper and lower first bicuspids, and you could do it with varying amounts of anchorage. So you can determine where the teeth are going to finish. So you hit this button right here that says VTO. And when you hit that button, it's automatically going to make a bunch of line drawings for you. Okay, so if I straighten Dominic's teeth, that's what he's gonna look like. And that makes sense. He doesn't have a lot of upper or lower crowding, so a little bit, but not a ton. Okay, if you fix the overjet with class 2 elastics, that's what he's gonna look like. That's gonna advance that lower incisor a lot. Okay, if you fix the class 2 by distalizing the upper, pushing the upper molars back, that's what it's gonna look like. You take out upper and lower fours, that's what it's gonna, I'm sorry, upper and lower first bicuspids, that's what it's gonna look like. With moderate anchorage, maximum anchorage, and upper fours only. Just take out the upper fours. That's gonna look the same as the distalization, okay? On him, pretty sure we went non-extraction. I mean, yeah, he's got some alginate on his teeth, but those teeth will straighten up real nice. Actually, you know what? I am incorrect. On him, we took out upper and lower fours, okay? Because we wanted to finish with his incisor near the starting position because of the lower incisor was at a good inclination to start and the vertical was good to start. So we went with this. Okay, I'm afraid if I would have gone extraction or non-extraction, the tissue would not have tolerated it well. Okay, and then that's the treatment plan I went with. Now, I think, oh no, I'm sorry, we did go non-extraction on him. I was incorrect. Something we could do on the bottom to this case I treated 100 years ago. Okay. We use an expanded wire on the bottom, and we used some IPR to decrease the lower incisor advancement. Okay. I thought we did it because of the transverse and to decrease the lower incisor advancement, but it was a non-extraction plan. Okay. So that gives you a general idea of how you're going through the cases, how you'll go through the tabs and go to the software. And then here is where it gives you instructions on how to treat the case. Now, this is a lot edited, so let me get you one that's unedited so you can see what it looks like. I'm going to open up the upper fours just so you can see what it looks like.
Shock, and you have 2 questions on the
Okay.
chat.
Thank you. So here's upper fours, and this is what the instructions look like. A line on round eye tie, then a heat wire. That's a different kind of wire, so increase the wire. Round eye tie gets the teeth straight. 18 by 25 heat activated gets the roots straight. Then you're going to put a keyhole wire in the upper. That's a wire with a little loop on it. Okay, and a straight wire on the lower. Okay, and what you're going to do in this case, now this is upper fours, but if it was a class 2 elastic case, you'd run class 2 elastics from the lower 6s to the upper keyholes until the case was class 1. Okay, so a couple of questions. Advanced mechanics using skeletal anchorage, orthodontic surgery. Can you please tell me what is that? The advanced class teaches you advanced skeletal anchorage. The basic skeletal anchorage is we're going to teach you to do upper and lower incisor intrusion, so that fixes the gummy smile. We're going to teach you how to do maximum anchorage, which lets you retract a lot. Minimum anchorage, which lets you close all the spaces by bringing the back teeth forward, and a canted occlusal plane. Okay. Things beyond that, where you're doing multiple coils, that molar intrusion I showed you, that's an advanced case. Okay. Changing someone's skeletal vertical dimension significantly, that's an advanced case. Okay. Those are anterior and posterior intrusion. Now, the one case I showed you with the girl with the gummy smile, that was anterior intrusion, but anterior and posterior intrusion. Okay. Now, somebody asked about a carrier motion appliance. Okay. You have to be careful about carrier. Okay. Because I think I'm one of the few people that has this information. Okay. Because I have an overlay on a case that I did a carrier on, and they used to call it a carrier distalizer, and it doesn't distalize. So that's why they call it a carrier motion 2. Okay. It really works the best with growth. Okay. I was shocked. I have a case where I thought I fixed 6 millimeters of class 2 in 6 months with a carrier motion. And then I had the founder of the company, Don McGann, overlay my start ceph and my final ceph to see what I actually got. And there was no dental distalization of that molar at all. Okay. But you could try it. I mean, in my opinion, carrier motion's better for teenagers and things like that, which is his case, an adult. The other things about carrier motion too, you have to be worried about, do you have posterior crowding? Do you have enough room for the 6, the 7, and the 8 in the maxilla, plus the amount you want to distalize? Okay, so you have to be cognizant of that. And you have to be careful because you can't distalize in a skeletally open case. So those are limitations to that kind of treatment. But it's appropriate in some treatments. Okay. The reason I showed you Dominic's case, even though I couldn't remember it from Adam, because it was 100 years ago, I couldn't even remember what treatment plan I used. You know why I used that case? Because I was in the office on Tuesday. And this lady comes in and she says she's there for an ortho consult for her daughter. Okay. And I thought I kind of recognized her, but I don't know. I mean, I see so much ortho. It's hard for me to, I was embarrassed the other day. I had a patient come in and say that brought one of their friends and they're like, oh, you did my ortho, remember? And for the life of me, I could not remember that person at all. That's horrible. That is really bad because I saw her probably 10 times, you know? So anyway, but the reason I brought this in, this is the patient that she brought with her. So hang on, let me show some of this. Let me shut this down. So this is the patient that she brought with her. I mean, look at her. She's beautiful. My God, she is a beautiful girl, right? Her teeth a little jagged. There's her profile. There's mom. Okay, there's her teeth.
I can't see the PowerPoint.
Oh, I'm sorry. All right, can you see it now?
Yep.
All right, so that last boy, his name was Dominic, right? So here she is. Okay, she's a beautiful girl. There's mom, right? Teeth are a little jacked up. Okay. Pretty class 1, class 2. Small upper lateral, see that? Pretty good rotation there. Few rotations here. And I said, well, so I said to her, I said to the mom, I'm like, well, you know, I can have, because this is what she's going to need. I think it's going to be non-extraction. You know, we can take some records, whatever. And I said, you know, I'll have the financial person come in and go over the stuff with you. Now I do same day starts, okay, because I've been doing this a long time, right? So I said, I can have the financial person go over things with you. If you want, I'll put the braces on today. Okay, that's me. Now you're not going to be able to do that. Okay. You know what she said to me? She said, oh, we're going to start. She said, you treated my son. Her son was Dominic. I didn't remember that. That's where I remember from. She said, he has the most beautiful smile. It's beautiful. You know what I said to her? I said, thank you. I said, that makes me feel so good for you to say that you thought my work was so beautiful that you want it for your daughter also. I mean, that touches you. Or maybe it doesn't touch you. That touches me. I mean, that makes me feel good because that means I changed somebody's life for the better. You know, how good does a patient feel whenever they walk out of the door and you did an MOD composite on number 19? And they're like, oh God, doctor, you changed my life. I'm telling you, I take people's braces off. You think I'm exaggerating, okay? I take people's braces off. I have mothers crying in the operatory when I take the braces off, because they're so happy for their child. You know, I'll tell you another feel good, warm, fuzzy story. I had a kid, people made fun of him all the time just because his teeth were jagged. You know, I straightened his teeth. He got his braces off. He came to the office and told me he overheard a couple girls talking about him and saying what a nice smile he had. You take a kid from being made fun of to proud of his smile. You don't get that in dentistry. Okay. It's a game changer. Okay. Ortho, here's the deal with ortho. Okay. Ortho, nothing in it is hard. You have to be good at one thing in ortho and one thing only, and that is adhesive dentistry. If you're not good at adhesive dentistry, if you can't get a bracket to stick to a tooth, you got a problem. But it's, you know what I do all day long? I glue brackets to teeth. I change ligatures on the little things. I change wires, and I'll put like a little spring here, a little this here, a little that there. The amount of stress is so much decreased. I had a day, I came home from work the other day really stressed out. And you know why? I couldn't get a banded rapid palatal expander to fit, so I had to send it back to the lab. That stressed me out. That's the worst it gets. You know, no more breaking off root tips and digging them out and all this other kind of stuff. My worst emergency, somebody has a wire poking them, okay? And I tell them to go into the bathroom and get a fingernail clipper and clip the wire. That's my worst emergency, okay? I'm contemplating on whether I'm not going to renew my DEA license. Why do I need a DEA license? An orthodontist isn't going to write a prescription for a narcotic, right? So, yeah, the orthodontist I work for, no DEA, no need, right? So it is what it is. So let me show you a case real quick, because we promised I'd show you a case. So let me show you a case that came into the office. Now this case looks kind of easy, but it's not kind of easy because it's an extraction case with deep bite. Okay, so that's kind of yuck. And I'm going to kind of go through this case kind of quickly because we only have 25 minutes. So I don't want to keep you any later than I have to, because it's Thursday night. And as we all know, Thursday is the new Friday, right? Especially here at the beautiful Hilton Oakbrook Suites. And the fine furniture they have, right? So this is Travis. This is a 15-year-old with a chief complaint of deep bite. Okay, Travis has a pretty nice profile, pretty straight. Okay. Ugh. Okay, that's a bunch of lower crowding, and that tissue is pretty thin, and I don't think that tissue can tolerate all that advancement. You will blow those teeth out of the gums. Okay, you cannot do that. Okay. He has scissor bite as his second molars. Okay, it's called telescopic bite, scissor bite, called a Brody bite. You can call it whatever you want, but it counts as cross bite. Okay. So significant amount of lower crowding. For those of you that don't know ortho, lower arch is the diagnostic arch. Lower crowding is diagnostic. Upper crowding is interesting, but not diagnostic. Okay. The rule in ortho school, if you go to ortho school, what they're going to teach you the very first day is make a good lower arch and the upper arch will fit it. Speaking of ortho school, let's talk about a couple of things. Okay. What are you going to learn in ortho school that you're not going to learn at POS? I get that question all the time. Shock, I'm thinking about going to ortho. I'm thinking about going to ortho school. I'm thinking about POS. Which should I do? All right. Well, what you're going to learn in ortho school is you're going to learn to make white, shiny models. You know, the ones that are white and shiny that have all the angles trimmed perfectly and have no bubbles. Yeah, you're going to sit in the lab and do that. Just like you carved crowns in dental school or whatever you did, set denture teeth, whatever you did. You're going to learn to do the lab work. Is that going to help you clinically? No. Okay, because you're going to make a digital model anyway, so that's kind of antiquated. Okay, you're going to get to write a master's thesis. How long is that going to take you? I think it's going to take a considerable amount of your time that could otherwise be spent learning clinical orthodontics. Okay. You're also going to learn some antiquated orthodontic systems. Okay, you're going to learn tip edge, beg. Okay, that's from the 1930s. Don't you think anything better's come around in the last 100 years? Why do you want to learn a history lesson? Okay, so clinical education, you'll actually get more with POS than you do in ortho school. Orthodontists generally know 4 treatment plans. Generally speaking, it's not always true, but the ones they know are non-extraction, upper first bicuspids, upper and lower first bicuspids, orthodontic surgery. That's what they know. How many cases do you think they treat beginning to end in a 2-year program? Well, the patient's going to have to start your very first day of ortho school so you can finish them your very last day. How many times do you think that happens? It doesn't. So what happens is you're going to treat other doctors that graduated. They're going to have patients that are midway that you're going to finish up. Okay. And you're going to have some that you start that you don't finish up that other doctors are going to finish for you. So you're not going to see it all the way through. Okay. Other things is you get to learn, earn while you learn. Okay. You go to ortho school, you're going to pay for it, right? A lot. Okay. You take POS. I want you to start as many cases as you possibly can as early as possible. Just dive in the deep end. Okay, don't stick your toe in the water. Dive in the deep end. If you really want to do ortho, you have nothing to worry about because, you know, I'll give you my email. You can email me and say, Shock, I'm having a problem. I get that email every day of my life. Shock, you know, what do I do here? What do I do here? You know, you expect a case to go a certain way, but what if the patient comes in at some point and you see something you don't expect? That's when you get nervous, right? And that's when you feel stranded. Well, that's when you email me or Dr. Taylor or any of the other instructors, and we'll be happy to get you on proper course again, okay? So that you can feel comfortable and so that you can sleep well, okay? Let's see. Okay, so there were just a few things in the chat. I didn't know if those were for me or not, so obviously not. Okay, so there's his pan. There's his Ceph traced, okay? Looks just like the tracing we did in dental CAD. And here's some of the numbers that are interesting, okay? He has skeletal average. That means you can take out teeth if you want or not take out teeth if you want. He is skeletal class 2. That means his bones are kind of far apart, okay? He has a retroclined upper incisor and a nearly proclined lower incisor, okay? So what we like to do, we like to straighten his teeth, fix the deep bite, fix the class 2. The problems are the thin tissues is the big one. Okay, so you straighten his teeth. That's what he's gonna look like. Is that an acceptable picture? There's no way his lower anterior tissue can tolerate that kind of advancement, okay? Take out upper and lower first bicuspids. That's what he's gonna look like. Is that an acceptable picture? Yes, that will maintain his profile and it will actually even advance his lower incisor a little bit, okay? So he had bicuspids extracted, okay? So in every case that we do, you're gonna see a PowerPoint like this and we're gonna design an appliance. We're gonna pick the brackets for the incisors. On him, he needed lingual root torque brackets on the upper incisors, lingual root torque bracket on the lower incisors. This picture is called a range of bracket torque. This helps you pick the correct bracket to get the best aesthetics. At POS, we work very, very, very hard to try to get the upper incisors to finish at the Roth ideal inclination. Okay, because that's the most aesthetic inclination. And that's where you want to finish up. Okay, on the lowers, we'll let you cheat a little bit because you can't see it as much. But on the upper, the aesthetics, man, that's right there. That is front row center, big time on the billboard. So that's got to look good. Okay, we determine the skeletal resistance. We pick the torque on the canines. All bicuspids get Roth brackets, not all, but the majority of bicuspids get Roth brackets. Okay, and then we have different kinds of bands that you can pick. There are bands made to compensate for known unwanted tooth movements. Okay. For example, if you run a rubber band from the top to the bottom, that's called a class 2 elastic. It's going to bring the lower molar forward, but the problem is it's not just going to bring it forward, it's also going to spin it. It's going to rotate it mesially, and it's also going to tip it mesially because you're pulling away from the center of resistance of the tooth. One of the centers of resistance is through the occlusal surface. If you pull from the buccal, it's going to rotate mesial, right? Another center of resistance is in the furcation. So if you pull from the crown, it's going to tip around the center of resistance and you're going to get a mesial crown tip, okay? That's why we have bands that before you do anything, during alignment, the band is going to rotate the tooth distal a little bit, and it's going to tip the tooth distal a little bit in preparation for that rubber band so that whenever you get done, the tooth's straight. Do I care that you remember all the theory behind it? No, but I'm glad you have something. At some point I do, but not right this minute. But do I care that your teeth end up straight? Absolutely, with as little work as possible. Okay, again, we have all these different wire shapes that you can pick from. There's the rotations. We have a vertical positioning. Now, whenever someone has deep bite, you want to put their brackets more incisively. For those of you that don't know ortho, extrusion is an easy tooth movement. Intrusion is a difficult tooth movement. Okay. I mean, extracting a tooth is relatively easy, kind of sometimes. Okay. But jamming a tooth further up into the socket, that's a bit of a challenge. Okay. So that's why extrusion is easy. Intrusion is difficult. Okay. So if you put the brackets on the incisors very incisively relative to the bicuspids are going to extrude, which helps open the bite. Okay. The first wire we use is like thread. Okay. It's a round NiTi. It's a nickel titanium wire. It goes back to its original shape. Okay. We use that to correct rotations. Okay. Here is round NiTi. Okay. It's a thin, flimsy wire. Okay. And what we're doing right now is letting the crowding unravel into the extraction spaces. Okay. We're going to go with that wire until you get into your next wire in the wire progression, which is called 18 by 25 heat activated wire. Now this wire is interesting if you've never seen it before. So give me just a second. And this is actually one of Dr. Taylor's videos, so thank you, Dr. Taylor. I'm not going to bore you with his voice, okay? But this is 18 by 25. The other one was 012. That meant it's round. If you see an X in the arch wire, that means it's rectangular. This is 18 thousandths of an inch tall by 25 thousandths of an inch thick, okay? And you can bend it a little bit because it has some copper in it. Okay, but what I want you to see is this. If you chill this wire, okay, watch 1001, 1002, 1003, 1004, 1005. Okay, now the wire becomes dead soft. Okay, there is no way in the world your teeth are that crooked. No possible way. And whenever that wire warms up to mouth temperature, it goes right back to its original shape. Okay. That's a powerful tool. Okay. Because what you can do, the name of the game in this setup is you've got to get the wire fully to the base of the slot. Watch 1001, 1002, 1003. Okay. There is no way your teeth are that crooked. If your teeth are that crooked, you need something beyond braces because that's pretty crooked. Okay. And it goes right back to its original shape. Okay, so why is that interesting? The name of the game is called Get the Pedal to the Metal. What does that mean? That means get the wire all the way to the base of the slot. That's the only way that you're going to get a full representation of the torque. So what you can do is if there's any place the wire doesn't go fully to the base of the slot, you can take a little endo ice or a little chilling pen or whatever and soften the wire mesial and distal to the bracket where it's not fully in the slot and tighten it down in there. And when you tighten it down in there, that's going to move the roots and give you a good expression of torque. Okay, so, and again, ortho, I hate to say it, but it's kind of boring. You're going to get so excited on your first case because you're going to think, oh, I can't make straight teeth. Because I'll tell you this is something I love. I've taught this all over the world. I mean, I've probably flown around the world 10 times, right? You know what every place tells me? That the university that they went to, the orthodontic education, was trash. And they said all it was an exercise to frustrate you and prove to you that you couldn't do ortho, so you wouldn't do it. You know why they do that? Because they don't want you doing it. You got to keep the numbers small so there's not very many providers so that we can charge an exorbitant fee, right? I'll tell you this too. I don't know if you look in the United States and see who is the highest paid profession in the United States, every year orthodontist is right there, number one, okay? I mean, they're right up there. They're top 5 for sure. I mean, they're making as much as the anesthesiologists and the surgeons and everything, and you're gluing brackets onto teeth. The hard part about ortho is there's just a lot to learn, but none of it is difficult. Nothing is difficult, okay? So what do we do on this guy? We glued brackets on his teeth and put a wire in there. All you have to do is sit and wait, and the patient will come back with straight teeth. If you've never done it before, you're going to be blown away because you're going to think, oh, I can't do straight teeth. You're going to put a nitrile wire in there. They're going to come back with straight teeth, and you're going to be like, wow, this really isn't that hard. So you put the round nitile in there. He had pretty jacked up teeth. So let's see how long it takes him to get straight. Okay, so there's 2 months. Top's already straight. Okay, 3 months, we're still straightening the bottom teeth. It's very common for one arch to be ahead of the other. The bottom's getting straight. You can't do anything until you have straight teeth. Okay, now that you have straight teeth, you put in that wire that I just showed you that you chill. Okay, this is an 18 by 25 feet activated. Okay. And this is a bicuspid extraction case, okay? So you tighten it up. Okay. This patient has they're class 1, but they've got a lot of overjet and they've got a lot of deep bite. The problem is when you retract those upper incisors to get rid of the overjet, the bite is going to get deeper. And you're already to the point where your upper incisors are not going to clear your lower incisor brackets. So you've got to do something about the deep bite. Okay. But still, to this point, all we've done is put in 2 wires and just let the wires work, nothing else. Okay, this is a little piece of open coil. I talked to you about a closed coil, closing spaces. This is an open coil where you open spaces. This is going to push the patient's midline over to his left. Now we're in 19 by 25 stainless steel. This is our working wire. This is the next wire in the progression. Okay, this is called a T-loop. Okay, T-loop is a method to close spaces. And that little bend you see on the top one, that's called a Snoopy bend. It's an intrusion bend. Okay, it's going to make it look like the incisors intrude. That's not really going to happen. The posterior teeth are going to extrude, but if you do it in the upper and the lower, the bite will open. Now, if you take the end of this T-loop wire and bend it, it'll spread the legs of that loop apart. Okay, if you spread the legs of the loop apart 1 millimeter, the front teeth will come back. If you spread the loops of the legs of the loop more, 2 millimeters or more, the back teeth will come forward. Okay, so you can control the tooth movements by how much you bend that loop. Okay, so we've got upper and lower T loops. Okay, with a Snoopy bend on the top. Patient didn't come in for 6 months, nice. Okay, Snoopy bend on the top. Deep bite didn't really improve. So I want you to do on the top and the bottom. There it is on the top and the bottom. Okay. And the deep bite's improving. Now I can see the entire bottom arch wire. Now we have some springs in the bottom. These are closing coils. These are what we use to close spaces. If you stretch this spring out a little bit, the front teeth go back. If you stretch the spring out a lot, the back teeth go forward. Okay. So here's some more of those closing coils on the bottom, closing the spaces. Okay, the bite is getting deeper because you're retracting the incisors. And now you can see they need to put a Snoopy bend in this again, but now you can see the legs are 1 millimeter apart. Now we're cinching back the T-loops to retract the incisors into the spaces. Okay. Lower spaces are closed. We want to lace them together. They were closed with those coils. And we're just going to keep cinching back the T-loops to retract the incisors. Cinch back the T-loops. Deep bite's killing you. Cinch back the T-loops. Now you got upper and lower Snoopies. Reactivate the loop. Reactivate the loop. Reactivate the loop. Spaces are closing. Same thing. Now they've got a closing coil in there to try to close the spaces. They are closing. It's just slow. Okay. Look at the improvement in the vertical. Okay. This was supposed to be a deep bite case where the bite was supposed to get deeper. Okay. We just kept making those Snoopy bends bigger and bigger and bigger. And finally, we got that bite to open up. Okay. Same thing. Now that we got all the spaces closed, we're going to put in our final wire, which is 018 stainless steel, which is a detailing wire. The way I explain things to people is during ortho, I'm doing big bulk tooth movements. In detailing, I'm finessing the case. It's what turns the case from an A to an A+. Okay. Little finishing here and there. And you give up. Okay. How's it look? I think it looks pretty good. I would like a little IPR in between these ones, or in between the centrals. Close that black triangle. Okay. I'm not crazy about that. You had a little space there. You should have chained that together. You just got a little decay there too, huh? Nice straight teeth. Bonded lingual retainer. Most people, we just give them clear overlays, upper and lower. Okay, straight teeth. Straight teeth. He looks thrilled. So, with that being said, you know, that's as promised. That's a case. Now, Dr. Taylor had a note on here that asked me if I would read. So let's see, Dr. Taylor. Dear doctors, once you join our program and start doing ortho, you will wonder how you ever practice dentistry without this knowledge. Single best thing you can do for your professional life and re-energize you to enjoy practicing more than you ever have. I know it's true from teaching and helping hundreds of doctors over the years. I hope to see you soon in a location that works for you. I will tell you this, as far as I go, ortho is the most gratifying thing there is. It's a game changer. You know the beauty of it? It's want-based dentistry, not need-based dentistry. People want ortho. They want to come see you. They don't want to come to get a filling. They need to come get a filling, right? You'd be surprised. I have very few patients miss appointments at ortho because they want their teeth straight and they want to get the braces off, right? So missed appointments is it's kind of a thing of the past. You get happy patients, you know what I mean? You're not giving anybody a shot, pulling their tooth, whatever. You are just gluing brackets on teeth, making them straight, giving them a beautiful smile. Okay, so I just wanted to go over a few things like that with you today, kind of tell you what we were all about. Okay, here at Progressive, you know, some of you know, some of you don't. If you know and you've been through this before, share it with your friends. Okay, it is a game changer. The one thing that I wish, and this is what I tell a lot of students, the one regret I have about POS is that I didn't take it earlier. Okay, and this is a killer. This kills me because, you know, I told you I work at a practice where, you know, the guy owns 7 offices or whatever, and they refer him to me. His big concern was, what's going to happen when I leave, right? Who's going to finish the cases, or how's that going to happen? So I offered to train his son. His son is graduated from dental school 3 years ago. I said, I will personally train this guy to do ortho. He doesn't want to. You know why? Because he did it in dental school and it was so awful. He can't imagine doing it in life. So he's just going to stick around with pulling teeth and filling teeth and whatever. So don't be that person. Okay, the things they've told you in the past, this is hard, it's not true. There's a lot to learn, I will tell you that. I mean, I can't teach you an ortho program in a weekend. Okay, that's why it's 48 days. You got to remember, I'm teaching you a 2-year program in 48 days, right? So that's moving. If any of you ever want to get a hold of me, I'm going to put my email on here. So HOCKMANDO@hotmail.com. Okay. So my name's Shock, and I'm a man, and I know how to do ortho. So Shock Man do, right? So you want to do what the Shock Man do, right? So all you got to do is email me and I'll help you out. Okay. I hope you'll consider taking the program. I hope, even if you don't at this point in time, I hope you'll consider it sometime in the future. We're the real deal. If you want to learn to do ortho, this is the place to come do it. This is just like ortho school education, only you don't have to go through all the nonsense. Okay. And before we go, I have to show you all one thing. Okay. Yesterday night at 8 o'clock, my first grandchild was born. I am so excited. I can't even stand it. So here he is. I don't know if you can see him, but that's my little grandson. Oh my gosh. I'm so happy. His name is Grayson. Okay. So I can't wait to get home from Chicago to see little Grayson. And so, yeah, thank you so much, guys. I'm thrilled. So, I just talked to my son before we got on here, and they are so tired, you know, because they're still at the hospital. They're going home tomorrow. So, so thank you for letting me share my blessing with you. Thank you for letting me share a little bit of knowledge with you, you know, and I want to share one more thing with you that somebody shared with me the other day. You know, before you go to bed tonight and tomorrow and every day, why don't you do something that makes you smile? Okay, just try to do one thing before you go to bed that makes yourself smile. Okay, and I hope I can join you in a seminar somewhere at some location, and I hope I can help you make a bunch of beautiful smiles. Okay, all right, so good night, everybody. Thank you for your time. If you have any questions, Yassine and Martha will be here. For those of you that I've seen around the world before, I hope I see you again. For those that I haven't, I hope I get an opportunity to meet you.